Okay, and then beside these suicidal thinking things, when we dispense antidepressant to the patient when they first started on it, we do tell them about the effect of the antidepressant, what's their expectation. Because some patients, they would expect that, oh, this one is for my mood, help to lift up my mood, is antidepressant, so I would expect it to, I'll get better in a few days' time. When over a few days or 1 week, when they see no changes in their mood, usually they'll just stop the medication. Yeah, so this one we really need to educate them on this, the effect of the antidepressant on the mood. We tell them usually is about 1 to 2 weeks time, you see slight improvement in your mood. But before that, is it that antidepressant never do anything, no changes at all? Actually, it does help a bit in to increase your appetite, help to improve your sleep, and it does help a bit to increase your energy level and improve your concentration. So this is what we usually tell the patient also. For the first 1 week or so, you may see some improvement in your sleep, appetite, concentration, and energy, so that they have some confidence in the medication that they are taking. Okay, and then we do tell them about some transient side effects that may occur, especially the anxiety with the SSRI. When you first start the patient on SSRI for first few days, the patient may feel a bit more jittery, a bit more anxious. Yeah, we do let the patient know about these side effects, but we reassure them that this one will go away after a few days when your body get adjusted to the medication. And some other common side effects that are transient when they are first started are like, for example, the very common one, headache, GI discomfort, and maybe like constipation or diarrhea. This one we do let them know. Okay, then then for for this SSRI, we all know that favoring fluoxamine is sedating. So we do tell patients to take it at night, and fluoxetine is activating. Tell them to take it in the morning, but it's not for all the patients. Yeah, we do have some patients who experience sedation with the fluoxetine. So we would tell them that you take this in the morning first, but if you feel very sedated in the daytime, you take it at night, but only once a day, and must let the doctor know when you come back to see the doctor. Yeah, this is how we educate the patient when the patient first started on antidepressants. Okay, yeah, that's about the how we manage the side effects, how we discuss antidepressant with the patient. So next we come to this concurrent use of benzodiazepine with antidepressant. It's actually indicated for coexisting anxiety, agitation, and or insomnia. However, it's only for short term, 2 to 4 weeks. Study has shown that it benefit in the first 2 to 4 weeks. However, after 4 weeks, 6 to 8 weeks, there's no much additional benefit with the use of benzodiazepine, but you actually increase the risk of tolerance, dependence, abuse, and also may increase accident probabilities, sedated and drive, then get into car accidents. So this is the thing that we need to bear in mind when we prescribe benzodiazepine to the patient. As far as possible, give it as a PRN and lowest dose as far as possible, and try to taper it off. So if we have a patient on benzodiazepine every day for 4 weeks already, do we stop it abruptly? We don't stop it abruptly. We taper it off also. Okay, how long to treat for? So for acute phase, 4 to 6 weeks to assess the response. If 4 to 6 weeks no response, switch to another antidepressant or augment with another antidepressant. For continuation phase, after the remission of the symptoms, 6 to 9 months. For maintenance, there's indication for maintenance treatment in the CPG on page 31, like which group of patient you need to put the patient on maintenance phase, even if it's a first episode of depression. Or if it's second episode, usually it'll be 1 to 2 years. More than 2 episodes, usually it'll be more than 2 years or even lifelong. And all this, it actually depends on the risk factor for the recurrence and patient's preference, whether patient want to continue the medication or not, or if there is no other risk factor, no other stressor, and how well the patient can cope with the stress in the life. So some strategy, if 4 to 6 weeks there's non-response or partial response, one of the strategy is to increase the dose of the antidepressant to the therapeutic dose, or even to the maximum dose. Okay, the other one is switching antidepressant. Switching would be preferred over augmentation or combination, because there's this general principle that monotherapy is always the preferred one. And when we switch, we can actually switch within the same class or to a different class. And the switching process is different for different class or even different drugs, and can refer to the Annex 6, page 64 to 66. It actually depends on the PD and the PK of the drugs involved. And when we switch, bear in mind to monitor for drug-drug interaction, especially serotonin syndrome, especially when we switch from SSRI to another SSRI, or we switch from SSRI to MOAI. Yeah, watch out for the hypertensive crisis also. And also the drug discontinuation reaction after the switch. So to augment the antidepressant, if there's no response to the adequate trial of antidepressant, no response at all, then you can consider augmenting, usually with the lithium or with thyroxine hormone. Usually we use a T3 triiodothyronine. Yeah, it's actually an exemption in Singapore. That means it has no product license. Only certain hospitals carry it. Yeah. Then for lithium-wise, if we want to put the patient on lithium as augmentation, then we need to look at the concurrent medication that patient is on also is on, especially ACE inhibitor. Yeah. If a patient on ACE inhibitor and lithium, we really need to watch out for it, because the concurrent use can actually increase the level of lithium by about 200% with the ACE inhibitor alone. Okay, and SSRI itself also has some to a certain extent, some interaction with the lithium itself. It may increase the level of the lithium or increase the risk of serotonin, but it's not very well established for this drug interaction. So far, there are only some case report or case series. However, we do need to monitor for it because lithium toxicity, it can be quite severe. So come to the last, discontinuing antidepressant. If we need to discontinue it, do it gradually over a few weeks or even a few months. Can cut by half of the dose. This is to avoid discontinuation symptom, especially with the antidepressant that have short half-life. Yeah, this is very common with paroxetine or fluoxamine. Yep. Okay, with that I end my talk here. Thank you.